Hi, I'm Dr. David Rubin. I'm a professor of medicine and chief of the section of gastroenterology, hepatology, and nutrition at the University of Chicago Medicine. I'm here today at the Mastering Clinical Challenges and Emerging Therapies in Inflammatory Bowel Disease, our annual meeting in the summer in Chicago, Illinois, our beautiful city. This meeting this year has some guest faculty from around the country, and we're covering a variety of topics related to state-of-the-art management of inflammatory bowel disease. I'm delighted to be joined for these key insights in this discussion with one of our visiting faculty, Dr. Gil Melmed, who is an associate professor of medicine at Cedars-Sinai Medical Center and the director of their clinical programs in inflammatory bowel disease. Dr. Melmed is also involved in the Crohn's and Colitis Foundation of America's Quality Improvement Initiative and has been a leader in our field in a variety of ways. Welcome, Gil.
Thank you, David. It's a pleasure to be here.
So we're halfway through the meeting, but we've covered a variety of important topics, and I wanted to just hit on sort of the headlines and also what the major changes are for our colleagues who are managing IBD patients. You gave our first keynote of the day when you talked about understanding longitudinal severity and choosing therapies based on prognosis. Can you sort of give us the take-home message from that talk?
Yeah, sure. I think that one very important shift in the way that we think about starting somebody on a new therapy at the outset is understanding where their disease is going. And that's really a shift because historically we've focused on patient symptoms at the time. We've categorized them as mild, moderate, or severe today. But the shift moving forward really is trying to get at what is their prognosis for a complication in the future and making decisions today based on that future prognosis. So rather than mild, moderate, severe today, let's think about patients as low risk or high risk for a future complication. And this is true for both Crohn's and ulcerative colitis.
So thinking about prognosis, not just how sick the patient is in front of you. And I would argue that that's not just when you're making your initial treatment decision at the time of diagnosis, but really every time you see your patient, because sometimes the prognosis and our understanding of that individual patient's disease is a moving target. Speaking of targets, one of the things you also brought up was the concept of treating to achieve a target and how you might incorporate that into advancing therapy for patients. Why don't you tell us a little more about where that is right now in the field?
Sure, yes. And again, this is also a shift, I think, in how we think about therapies and also involving the patient in the discussion of when we make a change in therapy. So the idea is that whatever decision point we're at with a patient and starting a new medication, starting a new treatment strategy, is that we've got some endpoint that we're looking towards. We've got some target that we're trying to achieve, and that we actually assess the patient within a certain time frame, whether it's 6 months or 9 months, to be able to determine whether we've achieved that target. If that target is reduction in inflammation, if the target is reduction in ulcers, or how a patient's symptomatically doing, it's really the combination of all those things, ideally, but to have the patient on board that we're not just starting this medicine going forward, we're starting this medicine with a very intentional target that we're trying to achieve, reassessing that target in that time frame, and then changing course if necessary if the target is not achieved, and continuing that cycle until we actually do get to a point where the target is achieved and we can then relax and go into a maintenance mode.
So I think the message that you really nicely explained to our audience today was understanding that you don't wait for a complication. The whole idea here is to be more proactive in monitoring a patient and to set up front what your goal might be. And you've nicely identified that there are different targets for different types of patients. I think that's really important. It's not all about mucosal healing for everybody. It might be about restoration of growth and development, or normalization of some other labs, and even sometimes when it's appropriate, the symptom management is an appropriate target as well.
That's right.
I think that when patients understand that we're not going to just wait until they can't tolerate something anymore or until they end up with a complication before we make any changes, that also enables them to feel a little bit more in control of what we're trying to do and explains our expectations. One of our other faculty members visiting today was Ray Cross, who is professor at University of Maryland and runs their IBD program. Ray spoke about mucosal healing. So right after your talk on thinking about targets and longitudinal severity, Ray gave a really nice talk on how we might try to achieve mucosal healing. Are you treating your patients to achieve mucosal healing? Let's start with ulcerative colitis.
Yeah, well, I think that ideally I would love to treat patients to mucosal healing and view that as a target. I think we do need to be careful about how we're throwing around the term mucosal healing and what does it actually mean. You ask about ulcerative colitis. I think within ulcerative colitis, we're talking about complete healing of the bowel, a little erythema, edema. Is that okay? I think that for ulcerative colitis, I'm okay with achieving, some of those milder markers of inflammation. But somebody's got ongoing ulceration, friability, which was a concept that Ray brought up as well. Those are patients that I'm going to continue to try to push to achieve better results.
Do you scope asymptomatic patients other than when you're doing surveillance?
That will usually be part of my conversation, going back to the treat to target concept, is that we'll have a plan. And the plan will usually include a colonoscopy assessment 6 to 9 months after changing a treatment. Sometimes that's not, I don't always do that, but I try to whenever I can get the patient buy-in, because I do think that it's important to be able to document. And we don't always have a great correlation between symptoms and endoscopic appearance, even in ulcerative colitis.
Yeah, very good point. I've started being specific to my patients about the distinction between clinical remission, which is them feeling better, and in colitis that means no urgency, no blood, being able to sleep through the night, and deeper levels of remission, which we'd like to achieve, but we don't always know if they've gotten there. And I found that even explaining what clinical remission is supposed to be gets me halfway there or more in most patients, because a lot of times patients think that, unfortunately, that they should just be able to get by with whatever they're living with, and then they're better, and better is okay. And better is really not okay in a lot of patients. What about in Crohn's?
In Crohn's, I feel more strongly to either do a colonoscopy or a cross-sectional imaging test, which may be the way that inflammation is best identified in those patients, as some kind of follow-up to determine whether we've achieved that target. Particularly when it comes to patients who've got deep ulcers in their small bowel, that's a very poor prognostic sign, and I think that those patients really, we need to be on top of those patients. And then clearly we know that there's a potential very big disconnect between symptoms and what we find endoscopically.
Yeah. I like to use CRP in Crohn's when they make it. If a patient doesn't make CRP, then I really struggle. I haven't been so convinced, and it may be just my own learning curve, that serial cross-sectional imaging gives me what I need. In other words, if I put someone on an anti-TNF therapy and then I repeat a CT enterography, I don't know if it's going to tell me enough to know that I've actually gotten anywhere. But I know our colleagues in Spain, for instance, are showing that MREs can do that. And I suppose that over a little bit more time, we'll have a better sense for some of those things. All right, well, so after that, we had a talk by Marla Dubinsky from Mount Sinai School, Icahn School of Medicine in New York. And Marla spoke to us about therapeutic drug monitoring. So one of the messages that she shared was that we're not just using therapeutic drug monitoring for loss of response, or at least we shouldn't be thinking about it that way. The audience shared their frustrations that payers still don't let us order these tests indiscriminately. But tell us a little bit more about how you're using therapeutic drug monitoring in your practice. Are you just using it for people losing response, or have you started being a little more proactive in that area also?
Yeah, no, I think this is an emerging area, and unfortunately, we are limited by what our health systems allow us to do, what our patients' insurance coverage allows them to do in many respects. So what I may want to do is not always what I'm able to do. I certainly would use therapeutic drug monitoring in a situation where patients are losing response, but as Marla taught us today, emerging evidence of the use of therapeutic drug monitoring proactively, as you suggested, even in patients in remission doing well. But also, importantly, another application is using therapeutic drug monitoring very early on after initiation of anti-TNF therapy in order to make sure that dosing is being optimized from the get-go, because sometimes it's really that early point in therapy that will determine the future response to the ongoing use of that drug. And so I'm starting to utilize early assessment of drug concentrations for patients starting anti-TNF therapy in order to know that I'm on the right track with them.
So what does early mean? When is that?
14 weeks with infliximab, and I would check it at around 8 weeks with adalimumab, although Marla showed us data today as early as 4 weeks with adalimumab may be the right time to be checking.
So I'm also doing this in some patients, especially high-risk people where I'm nervous that I'm not going to be able to get them where they need to be. Earlier measurements of drug have affected my dosing and changed my plan. The other place where I've used therapeutic drug monitoring is in somebody who's had a drug holiday. So we learned this from Barrett and colleagues and others now, where in a patient who had an interruption of their therapy for whatever reason, if you're going back to it, and you can consider going back to it, provided that it's not because they were allergic or had a drug reaction, checking a drug level a week after their resumption of loading might provide you with the information necessary to know whether you should continue or whether they're at high risk for non-response or other reactions. So I'm using it in that situation. The other place where I've used it is when we're considering de-escalation or when a patient's been on it for a really long time and I'm not even sure it's doing anything anymore. And that I sort of extrapolated from the STORY trial, where when we stopped infliximab, one of the predictors of doing well was the patient who had undetectable infliximab levels, meaning it wasn't even doing anything anymore anyway.
Right.
And occasionally I've been surprised that the patient who's been doing well for a long time actually has no drug present, and the drug isn't doing what we thought it was doing. The challenge we've all faced, though, is getting payers to cover it and understanding a bit more about some of the different assays that are around. So we did have a nice discussion about that today. I spoke about Vedolizumab at today's conference and just gave an update on where that is as a novel, newer therapy for us. It's been around now for a couple years. Tell us a little bit about how you're using Vedolizumab in your practice.
Well, I am using quite a bit of vedolizumab in my practice. Again, this is another area where sometimes the insurance constraints may impact my decision-making with the patient. For ulcerative colitis, I'm quite comfortable using vedolizumab as first-line therapy. I'm not often able to do so, but find it appealing. With Crohn's disease, I'm typically using it after somebody's failed an anti-TNF agent or has not been able to tolerate that.
Yeah, we went through a number of scenarios, and I also highlighted the most recent safety data that came out of the original pivotal trials, demonstrating in almost 5,000 patient years of experience, no new safety signals. So this does seem to be a safe therapy and appears to be a good option for us, either first line in some specific patients and certainly as a novel mechanism when the TNF mechanism doesn't seem to work. So speaking of mechanisms, Russell Cohen covered for us a lot of the newer therapies that are coming down the pike, and then Marla covered a little bit more from the DDW highlights. Just mention one or two of the drugs that you're enthusiastic about that we should expect to see in our field within the next year or so.
Yeah, no, I mean, I think that was very exciting to hear about what's coming out, because there's a number of new products being evaluated and investigated with a number of different mechanisms, as you say. I think over the next year we're likely to see introduction into our space in inflammatory bowel disease of ustekinumab, IL-12/23 inhibitor, which is already available for psoriasis, but will probably become available for Crohn's disease with an initial one-time IV induction dose, followed by every 8-week subcutaneous dosing. And this is a novel mechanism. It's available now for psoriasis, so certainly I anticipate my patients who've had psoriatic complications from their anti-TNF drugs or may have underlying psoriasis, that'll be a go-to drug, and another mechanism for those patients who failed anti-TNFs as well. So that's something that hopefully will be available in the very near future. And a second drug, which is a small molecule JAK inhibitor, tofacitinib. Again, another drug that's available in another disease state, but looks like will very promising data in ulcerative colitis, both induction and then hopefully maintenance, which will give another option for patients. This is exciting because it's an oral drug, may not have the immunogenicity concerns, non-biologic, and so. I think these both in the very near future will offer some exciting options for our patients.
So we're going to have new classes of therapy to think about, and that will really require that we be even more thoughtful about how we position them and how we evaluate patients who aren't responding to therapy or who have lost response to therapy. Well, for our final brief messaging, I wanted to highlight your really great talk today, updating us on the quality of care initiative in inflammatory bowel disease. So tell our viewers what's new and how far we've come in thinking about quality for IBD patients.
Yeah, thanks. Well, I think that when it comes to quality improvement, that means a lot of different things to a lot of different people. There are a number of quality improvement initiatives that are out there in the GI space. Some of them are available to gastroenterologists through the AGA or through the ACG, which allow gastroenterologists to attach themselves to these programs and report on quality measures in order to avoid reimbursement hits or potentially receive bonus payments. But quality improvement goes really beyond the measurement and reporting. It really goes to the heart of improving our ability to care for our patients. And in that respect, there are some programs that can enable and facilitate that, such as the Improved Care Now organization with pediatric IBD, our CCFA program called Chorus, which now 20 sites are involved with, that has a structured way of initiating quality improvement. But quality improvement really doesn't require being part of a program. It requires the passion of the provider wanting to make things better. Mm-hmm. And we spoke about some ways to be able to do that. Think of one measure that you want to improve upon, whether it's looking at vaccination rates, whether it's improving the time it takes to return a phone call or see a patient who needs an urgent visit. There's very small changes that one can make in one's practice to facilitate improving those particular measures and outcomes that will have an impact on patient care. And one of the themes I really wanted to drive home was that you don't need a program. You can do this on your own, and that you need to start small. Don't need to think big. It doesn't require a whole change in your electronic medical record system to change towards a quality improvement initiative. Just pick one little area that you want to work on and make iterative improvements over time. That's really a tenet of quality improvement, is that it's iterative improvement over time.
Yeah, that's a really important message. You definitely taught me that. These small changes, getting things moving and then continuing to make improvements over time is really great. Where can people go if they want to learn more about what you're doing?
The CCFA website talks more about our course program, and there's a video that they can watch and also gives information about what the program is about and how they can participate.
Great, so ccfa.org. Well, joining me for our clinical insights and key insights from the Mastering Clinical Challenges and Emerging Therapies in IBD meeting in Chicago is Dr. Gil Melmid, and I'm Dr. David Rubin, and I want to thank you all for joining us.